Good morning. I see a lot of faces that I actually know from Baltimore, but I'd like to spend some time this morning talking about non-muscle invasive bladder cancer. I'm going to reiterate a lot of what you've already heard and then talk about treatments. I think that this is probably the most important, really a large portion of the patients that we see oftentimes will have non-muscle invasive bladder cancer, and treatment of these patients is very important because the goal here is to prevent progression. By way of disclosures, I have a number of grants as well as I'm a PI in a clinical trial, which really isn't related to anything I'm going to talk about today, but nonetheless, these are my disclosures. We've already seen this slide, but what I'm going to talk about right now for the next 15 minutes or so is the treatment of urothelial carcinoma, transitional cell. Treatment for squamous cell and adenocarcinoma of the bladder are completely different and separate from anything I'm going to talk about. So what I'm going to speak about now is urothelial carcinoma and treatment of non-muscle invasive transitional cell carcinoma. We've also heard about staging. When we consider treatment of non-muscle invasive bladder cancer, it's treatment of CIS, TA, either low grade or high grade, or T1. Treatment for T2 and T3 lesions or T4 lesions are obviously going to be a focus of another talk later this morning. So when I consider treatment of non-muscle invasive bladder cancer, and any urologic oncologist in this country, we are considering treatment of low-grade lesions and high-grade lesions. Typically, patients are followed, when patients are diagnosed with a low-grade lesion, they can be followed with serial cystoscopy, and in the absence of recurrence, really need no further therapy. However, if a patient has recurrent low-grade urothelial carcinoma, then we seek more other options, including mitomycin C, which I'll talk about. High-grade lesions, these tumors are really have a high propensity to recur and to ultimately progress. So if a patient has a high-grade lesion, then we automatically are going to recommend some form of intravesical therapy. And typically, the type of therapy for high-grade lesions always is to start with BCG, which I'll go over. Urothelial carcinoma, it's really two different phenotypes. These low-grade and high-grade lesions have completely different molecular basis and therefore are considered really two separate diseases in my mind. Superficial, as it used to be termed, or now non-muscle invasive bladder cancer, if it is 70-80% of patients will have this type of lesion. The majority if they're low grade, really, these are considered pesky tumors. They will come back and not necessarily progress. So when I tell patients, I say, listen, this is a pesky tumor. We might be able to watch this, and if there's signs of upgrading to high-grade lesions, then obviously we can consider doing more aggressive therapy. 50% of all non-invasive tumors will recur, and I'll go over those that are more likely to. The mainstay treatment, as you've just heard, is transurethral resection of bladder tumor with intravesical chemotherapy or immunotherapy. Muscle invasive disease, which we're going to hear about later this morning, 15% of all muscle invasive tumors actually started off as non-muscle invasive. So we always have to consider this, and this is why we follow patients so closely with non-muscle invasive bladder cancer. Of course, if you have muscle invasive disease, this is always high grade. We also just heard about the staging system for treatment of non-muscle invasive bladder cancer. If you have a papilloma, as we just heard, this is a tumor that may recur, unlikely, but may, and really has very little chance of progressing to a more aggressive phenotype. The pun lump, as we term them, 35% risk of recurrence and only 4% risk of actually progressing to a low-grade or high-grade tumor. And typically, if you have a pun lump tumor, it's usually solitary. It's not multifocal. And if it does progress, it usually progresses to a low-grade lesion. Low-grade urothelial carcinoma, 50% have a recurrence rate, and 10% can progress. And the patients in my practice that have low-grade tumors, these are the folks I say, listen, this is a pesky tumor. We're going to watch this because it can recur and may recur, 50% do, but it's unlikely to progress. And if it does progress, we want to catch it at an early stage. High-grade tumors, these are the ones that have the most frequent recurrence rates, and 25 to 65% may progress. So these are the patients that we're going to give intravesical chemotherapy, immunotherapy. And as we just heard, CIS is a high-grade tumor and should be considered and treated that way. This is the old staging system, which we also just heard about. This is a paper from O'Connell, who's really done the most really comprehensive research as well as clinical trials on treatment for non-muscle invasive bladder cancer using various forms of intravesical chemotherapy. Here on the left, we see that if you've got a low-grade tumor, 30% recurrence rate, less than 5% will progress. So if you're a patient and you're looking at it and you're saying, is this me? Well, these are people with low-grade tumors, stage TA, so mucosal only. There's no dysplasia. You have negative cytology. Usually it's a solitary lesion. It has a papillary configuration. It's small. And really, we don't treat these with any type of intravesical chemotherapy initially. However, if it progresses or becomes recurrent, then we consider that strongly. Here we have the moderate, sort of the stage 2, and then the high-risk features. If you've got a medium-sized tumor, it's a TA or a T1 lesion with some urothelial dysplasia. You really don't have a positive cytology or high grade on cytology. It's multifocal. It may recur, but only may recur, say, a year or two later, and actually is now getting to be bigger. Well, these are the type of tumors or patients that have a higher rate of progression. And if you have a high-grade lesion with stage T1 where you're approaching a T2 lesion where this lesion is actually growing deeper into the lamina propria, closer to that detrusor muscle. You've got associated CIS concomitant with it, as well as a positive cytology. You also have multiple tumors with lymphovascular invasion. These are the patients that we really are very concerned about and need to be very aggressive with our treatment. So the importance of proper staging. As I just pointed out to you, depending on your stage, depending on your high-risk features, we really need to consider being aggressive with our treatment. And I am extremely aggressive with treatment of bladder cancer. Restaging TURBT, as we just heard, in my practice, if a patient comes to me and has a T1 lesion, high grade with associated CIS, even if there's a muscle in the specimen, I still bring them back to the operating room for a restage in TURBT. And I can assure you the two urologists that just spoke do the exact same thing. 20 to 30%, as we just heard of these patients, actually have an upstaging. We upstage them to T2. And as you know, treatment of a T2 muscle-invasive bladder cancer is very different than non-muscle invasive bladder cancer. So the last thing I want to do to a patient is delay their treatment, their ultimate necessary treatment, because I didn't bring them to the operating room and do a restage in TURBT. And also, we want to make sure that we rid that bladder of any residual tumor, because as we know, BCG can be effective for primary tumors and treat that. However, that's very unlikely. So we want to be able to clean that bladder out, get all of the tumor there, so we can then give them appropriate intravesical chemotherapy or immunotherapy. Here are the NCCN guidelines for the treatment of non-muscle invasive bladder cancer. This is the National Comprehensive Cancer Network. This is sort of our Bible when we look at any type of treatment of any cancer of the GU tract. Doesn't matter if it's testis cancer, prostate cancer, bladder cancer. Here you see a TA lesion, low grade. What do they recommend? You can observe. You can consider a single dose of intravesical chemotherapy within 24 hours of removal of that tumor. So this is sort of a very difficult thing for urologists, because we bring you to the operating room and we remove this tumor and we say, well, this may be low grade, it may be high grade. So we have to make a judgment call here. Do we give you what's called mitomycin C into your bladder after resection? In my practice, if I have a patient that has what appears to be a non-muscle invasive tumor, I will oftentimes and will administer mitomycin C after the resection. Why do we do this? Because there's clear evidence that this reduces recurrence of tumors. The mechanism by which it does that is to essentially prevent implantation of any cancer cells that are floating around in the bladder from touching another part of the bladder and growing. So this is extremely important and oftentimes not used. There was actually it was a nice study that used the Medicare database. So this is all patients that had Medicare, and they actually polled it to see what percentage of urologists in this country actually perform administer mitomycin C after resection of the bladder tumor. And believe it or not, less than 10% of all urologists in this country actually did it. So this is clear evidence that this works to prevent low-grade tumors. However, we're not doing it. We need to do better. Here, if you've got a TA, high-grade lesion, if the urologist believes that this was an incomplete resection and there's no detrusor muscle, deep muscle in the specimen, then you have to go back and perform a repeat restaging TURBT and then administer intravesical chemotherapy. If you have a T1 lesion, either low-grade or high-grade, recommend, once again, restaging TURBT, and then administration of BCG or mitomycin, which I'll go over shortly. So here, once again, are the guidelines for administration of intravesical therapy. Here, once again, immediate perioperative administration of mitomycin C. This is recommended within 24 hours if a patient is thought to have a low-grade, non-invasive tumor. If you are to administer either chemotherapy or immunotherapy, which is BCG, we oftentimes will wait 4 to 6 weeks to administer this, and this is a common practice. Everyone has a different sort of protocol for what they do. In my practice, I wait 4 to 6 weeks. And then I'll go over the details of this in a second. So how do we manage this? Once again, I'll reiterate, if you have low-grade tumor, it's not multifocal, maybe a small papillary tumor, I don't mind just doing follow-up endoscopic evaluation, cystoscopies. If you have CIS in particular, a high-grade TA lesion or T1 lesion, then you're going to get some form of intravesical chemotherapy or immunotherapy. Here are examples of the intravesical agents that are used in urology today. I will say some of these are not used as often as others. In my practice, I would say in BCG, mitomycin, and the combination of BCG with interferon are the most common used, and I'll go over these in detail. So BCG, what is it? Oftentimes patients come in and say, well, what is this thing you're giving me inside my bladder? Is this systemic chemotherapy? Is this local chemotherapy? Well, it's actually immunotherapy because it's an attenuated mycobacterium developed as a vaccine for TB. And the way that this was utilized is that it was shown to have very specific anti-tumor activity in a number of different cancers, including urothelial carcinoma, both in vitro and in vitro. So if we grow it in a petri dish, we can inhibit a progression or tumor growth, and then if we put it into a preclinical animal, we can also inhibit its growth using this type of immunotherapy. And once again, we typically start this 4 to 6 weeks after your TURBT. So the story goes, and if you talk to Alvaro Morales, who was the very first person to do this, he's actually at Queens in Canada. He was the first person to actually administer this, along with Brossman. And the way he decided to give 6 doses was that when he ordered the BCG, it came in a 6-pack of jars. So essentially, he gets this in the mail and he gets 6, and he says, "Well, I guess I'll do 6." And if you talk to Morales, he will tell you that urban myth is actually true. That's how he decided that he was going to administer this. But what I would tell you and show you very shortly is that it's highly effective. So in the office, it's reconstituted into water. We use Tice at Hopkins. I'm sure this is the most common used, I think, around the country. We reconstitute it in 50 milliliters of saline. It's administered through a urethral catheter. The nurses place a catheter, and then you instill this into the bladder. And then what we ask is that you hold this in the bladder for about 2 hours. Oftentimes, patients will read on the internet, on the blogs, that, do I need to stand on my head, stand on the move around, do a flip, whatever it may be. What I do is I essentially just let the patient be comfortable. If you move to the side, right, to the left, move around, you're going to get essentially a good coating of your bladder. Treatments, once again, are started anywhere between 2 weeks to 6 weeks. I do not start BCG administration 2 weeks. Why? Because the bladder really just hasn't healed well. If anybody in this room has ever had a TURBT, all patients say, I feel terrible. I go to the bathroom often. It hurts. I'm burning. I'm bleeding. So we wait for the re-epithelialization of the urothelium. Believe it or not, the bladder, the lining actually grows back within 48 to 72 hours. However, that whole process of healing takes actually a couple of weeks. So before we administer, we always want to make sure that you do not have an active infection. So we will get a urine analysis before administration of the BCG. And once again, anybody that's had this done, they will tell you that we always check a UA. In my practice, as long as you don't have a raging infection, don't have really evidence of an active infection, I don't mind giving BCG. Once again, there's evidence to show that you can actually give BCG while you have an infection, and it can be safe. However, I do not feel comfortable doing that. If you have a traumatic catheterization, if the nurse places the catheter, you have bright red blood, you have active bleeding, we will not administer the BCG. I usually wait a week and then try again. And then once again, we try to keep it in the bladder for about 2 hours. So here are the contraindications for BCG. The absolute contraindications, if you have an immunosuppressed or immunocompromised patient, this actually could be a patient that has chronic COPD, is on steroids, and really can't. This is a very tough call for us when trying to consider administration of BCG. These are transplant patients, may have a kidney transplant. Believe it or not, we actually get a lot of patients with kidney transplant referred to Hopkins for this exact reason, because they are immunocompromised and their treatment is complex. If you had an immediate transurethral resection, a history of BCG sepsis, BCG can give you a very serious infection. And if you've got a history of an infection that you were hospitalized and actually were sick, then this is a contraindication. If you get hematuria, traumatic catheterization, and then, as we know, bladder cancer affects older geriatricians, octogenarians. So a lot of women, especially, can't actually hold this in their bladder. So if you can't hold this in your bladder, then there's no reason to give it. And oftentimes this will be a contraindication. And in my practice, I actually place a catheter. I'll even blow up the balloon and actually allow the catheter to sit in the bladder, and that way the patient doesn't leak the BCG or mitomycin. And then here are the relative contraindications, and as well as other reasons for insufficient data to give a recommendation. So when we oftentimes, first-line treatment for CIS is BCG. And what we know is that that progression rates of CIS to muscle-invasive disease is actually 7% per year. And approximately 50% of patients experience a durable response for up to 4 years given BCG. So we always give this when an individual is diagnosed with CIS. Over a 10-year period, approximately 30% of patients remain free of tumor progression and recurrence. So we can actually cure 30% of patients that have CIS with BCG. And if you are to recur, that recurrence rate is actually within the first 2 years, but if you are to recur, it usually recurs within 2 to 5 years. And actually, we just heard about some of the data from Harry Herr. TUR alone, if we just remove your tumor and you have a high-grade T1 tumor, survival rates at 10 years are 55%. However, if you administer BCG to this exact same patient, this improves to 75%. So if we have an effective treatment, we will always administer and recommend this. This is also a very common question that patients will ask us. Well, I've gotten one course of BCG, and now I have a recurrent tumor. What's my chances of getting of this being effective? Well, this is actually a very old article from Bill Catalona, who's actually trained at Hopkins and is at Northwestern, and is actually known for his prostate cancer research on PSA. But back in 1987, he showed that you can salvage up to 50% of non-responders if you give them a second induction course of BCG. And if you look at this, if you have a failure after 2 courses, your risk of progression is in development of METs is actually not insignificant. So I will oftentimes give patients a second induction course of BCG, but if you fail after that, then there's no reason or no data to support to give you another induction course of BCG. Induction means 6-week course. So oftentimes we also get maintenance. What about maintenance? Should I do this for the next 2 years? Well, the data to support this is from Don Lamb. This is a SWOG. This is the Southwest Oncology Group. Performed a study in which Lamb proposed an induction versus induction plus 3 weekly BCGs at 3, 6, 12, 18, 24, 30, and 36 months. As you can see, this is a very rigorous protocol, and only 16% of patients actually completed the maintenance protocol. Why do we know that this is important? And I recommend to all my patients because the recurrence-free survival was actually improved in those patients that were on maintenance, 60% versus 41%. And progression-free survival, which means you progress to muscle-invasive disease, actually improved slightly, but still 6% improvement. So in my opinion, if you can tolerate this and you can do it, I think we should, and I recommend for all my patients. Importantly, he saw no difference in overall survival at 5 years. But nonetheless, he was able to prevent recurrences, and he had a slight improvement in progression-free survival. What is our typical post-treatment monitoring? Cystoscopy for 3 months after 2 years, cystoscopy for 6 months after 2 years, and the cystoscopy for every 1 year. We always get annual imaging. In my practice, if you've got a high-grade lesion, you always get a CT scan, the CT urogram, as we just heard from Dr. Riggs, once a year. I get a cytology with every cystoscopy at each one of these time points, and the use of molecular cytology, as we heard about from Dr. Riggs, is also available. That is oftentimes debated as to when we should use this, how we should use that, and I can spend a whole day talking about that, but ultimately, cytology, I would say, is our mainstay. So what about mitomycin C? This is also a type of chemotherapy, not immunotherapy, which is actually an alkalizing agent. It inhibits DNA synthesis, and we administer this when you get a mitomycin C intravesical chemotherapy for 8 weeks, not 6 weeks. However, it ranges in most practices between 6 to 8. Once again, in my practice, it's 8 weeks. We try to optimize this type of chemotherapy into the bladder by asking the patient to eliminate all residual urine. We always overnight fast, we alkalize the urine, and then we administer it in a dose of 40 milligrams. Why do we do all these things? Because there's data to suggest that if you alkalize the urine and with bicarb, and you fast overnight, you get better penetrance of this chemotherapy into the bladder. So this is a protocol that we use at Hopkins. This is oftentimes used for patients that have recurrent multifocal low-grade lesions. And if you look at meta-analysis comparing mitomycin to BCG, mitomycin can be effective for the treatment of high-grade tumors, in particular T1. However, when you compare it, BCG beats out mitomycin in all the meta-analysis. So if we go back to our NCCN guidelines, here we've got a patient has recurrent cancer after some induction course of BCG or mitomycin. What are our options? Well, you need to do a TURBT if they have a complete response, which means you've done your TURBT and you have no residual tumor. Then they can go on a maintenance BCG as an option. However, if they have residual tumor, either CIS or TA, then we're going to change them to a different intravesical agent. It may actually be a second induction course of BCG. It could be mitomycin, could be a BCG with interferon, which I'll talk about shortly, or Valstar. If you have a high-grade tumor, T1 with lymphovascular invasion, then you really have to consider a cystectomy in this patient, because really these are the ones that are at very high risk for progression. So what is BCG with interferon? Once again, O'Donnell was the sort of champion of this intravesical immunotherapy. What he first studied was interferon alone, and he found that interferon alone was ineffective in reducing recurrence rates. However, if he combined this with BCG, he could actually improve the efficacy of this immunotherapy. So once again, we oftentimes will have a patient who gets an induction course of BCG. They may have a good hiatus of recurrence of their tumor for, say, 6 months to 2 years. If they then recur, we oftentimes will give them another type of immunotherapy. Here we use BCG with interferon. And there is data to show that this can salvage or capture and improve recurrence rates. So what are the factors that influence outcome with BCG with interferon? If you have a papillary or CIS tumor, there's really no difference. If you have a TA or a T1 lesion, these are once again the high grade, confined to the mucosa or the submucosa. Really, you have the same results when compared to the high grade tumors. If you have failed BCG, really we see that this can be effective. If you have low-grade tumors, really BCG with interferon isn't effective, and oftentimes we'll use mitomycin C. If you've had residual disease, you've had multiple TURs, you have multiple tumors recur, you have a long duration of cancer, which means you have essentially had bladder cancer for many years, you have failed multiple courses of intravesical chemotherapy. These are all the factors that say, listen, let's not try BCG with interferon. Let's not try another induction course of BCG. You need to consider very strongly removal of your bladder. What is Valrubicin? This is an FDA-approved treatment for BCG refractory CIS. This was approved for patients that have failed BCG, either 1 or 2 courses of BCG, and only have CIS in their bladder. So if you have a high-grade tumor, T1 tumor, with CIS, this is not FDA-approved, Valrubicin. It's only approved for CIS after BCG failure. Once again, this is a 6-weekly installations of 800 milligrams. The side effects to this are urinary frequency, urgency, and dysuria. This is the pivotal trial. Gary Steinberg, who's at the University of Chicago, did this trial, and what he showed is that 90 patients with recurrent CIS who failed intravesical BCG, he can have a 21% response rate by salvaging them with Valstar. So this is an option. If you have failed BCG and have only CIS, then Valstar may be an option. Who were those patients that did not respond to this? Those were patients that had T1 lesions or other types of papillary lesions. So take-home points, intravesical BCG has a higher efficacy than intravesical chemotherapy. That's mitomycin C, I will call it. BCG is the only agent shown to delay or reduce high-grade tumor progression. Maintenance BCG reduces recurrence rates. And interferon with BCG combined is an option to salvage those patients that fail BCG alone. I'll end there. Thank you.